Good evening. I see that there's some people joining, but I will definitely give it a couple minutes to make sure everybody has a chance to log on. See, we have people adding quickly, so I will continue to give it a couple minutes to give everybody a chance. Well, good evening. I can't see most of you, but I can see some of your names, and I'm very happy to recognize a good handful of those here listed. My name is Paige Harrington. I'm a veterinarian that works with Vets Pets, and I work very closely with the Points East team. I'm actually sitting at Points East Veterinary Specialty Hospital right now in Wilson. It is really fun to be able to bring these CEs to you guys on the last Tuesday of every month. So thank you for coming and making time to attend. For tonight, if you have questions, and we can't see you or hear you, but I will be monitoring the chat. Feel free to put any questions in there. If there's a question that I feel is really pertinent to the slide that we're on or the exact topic that we're on, I will interrupt Dr. Mathis and ask for clarification. If it's something that I feel like can wait, then we'll have a Q&A session at the end. So go ahead and put it in, and I'll kind of determine when to interrupt and ask that question. And anyone that is attending tonight, this is considered a live interactive CE for the medical board. So I know some rules have changed this past year as far as what is in person, what is online. Right now, we can do all 20 hours online, but 10 of those hours have to be live and interactive. And this is considered a live and interactive CE. And you will be receiving your CE certificate in the next week. So just be looking out for that via your email. Those that are interested in attending in future months, in May, we will have a chronic enteropathies topic. In June, we will have, it will be the fracture management prior to surgical referral topic. And then in July, we will have a topic about moral injury, which I actually attended that CE this past weekend and found it really informative and helpful. And so now I would very happily introduce Dr. Mathis. So Dr. Justin Mathis and I were introduced to be a past extern at Points East Veterinary Specialty Hospital while he was working down at Mississippi State. As he was very interested in moving to Eastern North Carolina and wondering where in the world is he possibly going to work if that's where he wants to live. And just so happens we have this unique little hospital here in Wilson, North Carolina. And so Justin started here with us on March 1st, but his background is quite extensive. Growing up on a beef cattle farm in Mississippi makes him a perfect person to be serving a very diverse clientele and a very diverse patient load here in Wilson. He earned his DVM from Mississippi State in 2009. And then he went on to do his internship at Colorado State, where he stayed for his residency, a master's degree in clinical sciences, and also a critical care fellowship. He became a diplomat of the Emergency and Critical Care College in 2013. Between 2014 and 2018, he was an assistant professor at CSU and then transferred to a private practice in Boulder before moving to Mississippi about a couple years ago. And now he has found himself here in North Carolina, where he's definitely planting some roots, because on the side, he is a hobby farmer, I'll call you now. I know you grew up on a big farm, but he has cattle and peacocks and ducks and goats. And the more of the stories you listen to, the more animals that are included in those stories. So dogs and cats by day, and then anything that will live outside on the weekends. So Dr. Mathis, thank you again for joining us here. And just so happens that we had a heat stroke come in around 6:30 this evening. So summer is definitely coming, and we all need to be prepared for the heat stroke patient. So I will go ahead and turn it on to you. And again, if you have any questions, put them in the chat, and I will navigate when to ask that question.
Thank you, Dr. Harrington. Thank you for that warm welcome and introduction. Yes, thank you all for joining us this evening. This is my first CE to provide, and I'm very happy to be a part of this team and able to provide this for you. I look forward to doing this in the future as well. As Dr. Harrington mentions, it's kind of serendipitous that we have this topic this evening. My sister actually called me from Mississippi last night in panic. Their dog was actually experiencing signs of heat stroke. And then we currently have a dog on the exam table right now in triage that's being treated for heat stroke. So, as Dr. Harrington says, heat stroke is here because summer is definitely here. But go ahead and get started. Many of you know the moment our lives changed in veterinary medicine when the wonderful dog show moment when the Frenchie became extremely popular. We actually treated a dog earlier today for signs of heat stress, heat stroke, and upper airway obstruction. And so we see these more commonly, and so being prepared, especially with the commonality of the brachycephalics in our profession these days, it's more important to be aware of the clinical signs to watch for, and then current therapies and recommendations for treating heat stroke. Obviously, there's been a lot of public education, especially with the commonality of the brachycephalic breeds. This is just one example of some of the things that are provided to clientele through hospitals, through just public education, for things to watch for. And in fact, this poster probably was at some point distributed to the client who's actually on our triage table right now. They were able to apply cool water to this dog prior to admission this evening. And the dog was left outside approximately 2 hours with about 85% or 85-degree ambient temperature with a fairly decent humidity today. And the dog was still 106 degrees on presentation, but they had appropriately wet the dog down and placed a fan on it in the car, or the air in the car, while driving here. So these things are very helpful, and I usually recommend these for the hospital, or have handouts for clients, especially starting this time of year, because we see this so commonly here in the Southeast. So heat stroke, by classification, is the most serious heat-related illness that we deal with. As you're aware, there's kind of two classifications. There's what we call exertional heat stroke or heat stress, and that's actually what my sister's dog experienced last night, where she said that he went outside, found the neighbor's dog in their yard, and they ran up and down the fence, kind of racing each other for an unknown amount of time while her fiance was home. And when they were kind of figuring out what had happened, the dog had come inside, was foaming at the mouth, was overtly kind of just struggling to make it in the door. And that would be like an exertional heat stress, versus non-exertional is your classic heat stroke. And unfortunately, sometimes that's like the dog that gets left in the car with the windows up at about this time of year. But we see both of them quite commonly on the clinic floor. Heat stress and heat stroke, and we like to define things, and I'll give a definition on the next slide. But usually, unfortunately, it results in multi-organ dysfunction syndrome and organ failure, where we talk about where the CNS or central nervous system's signs or dysfunction predominantly are the most common thing that we see. But also, there's many other organ systems affected, and we'll go through those a little bit later in this talk and talk specifics about how to manage a little bit of that multi-organ dysfunction. So heat stroke is a continuum, and this is part of the recognition of heat stress and heat stroke. So it begins with heat cramps, and this is mainly leaning on that exertional side of heat stroke, where we start to see very fine muscle spasms, and this is due to dehydration and depletion of sodium and chloride at the cellular level. And a lot of times, owners will miss this kind of early onset of heat stress or heat stroke, because they'll just interpret it as, well, they just got tired. They're just laying down, and they really miss that heat cramp phase. Then the pet will progress into heat prostration and exhaustion. And so this is actually where my sister called me last night, where their dog was showing overt signs of fatigue and weakness. He actually had vomited and had some soft stool by the time she had called. He wasn't necessarily having any tremors per se, but his mentation was definitely depressed. And so he was already going into heat prostration. And I think one of the reasons, which I'll allude to later, of his turnaround is she caught him soon enough. But unfortunately, without intervention, it usually is a continuum into fulminant heat stroke, which is what we see a lot of times on the clinic floor, which ultimately, as we mentioned, is represented by CNS dysfunction and then ultimately multi-organ failure. Okay, here we go. So like I said, in veterinary medicine, we like definitions. And so heat stroke by definition is hyperthermia associated with a systemic inflammatory response leading to a syndrome of multi-organ dysfunction where, and I put it in bold, encephalopathy predominates. And so we're all familiar with the repercussions of heat stress and heat stroke and the kind of SIRS response that we see. But one of the things I asked my sister last night was, how is his mentation? How is he, will he respond to his name? Does he seem to know what you're speaking to him and you're talking with him? Because the encephalopathy is something that we can often look at and we'll talk later, even prognosticate on. And kind of intuitively, it's not necessarily the ambient temperature or the exercise that is the problem. It obviously leads to the heat stress or heat stroke, but it's really that rise in core body temperature that really incites this systemic inflammatory response and ultimately this cascade of things that lead to multi-organ dysfunction syndrome. And so we'll talk a little bit about our cooling methods specifically for the treatment of heat stroke. And what we need to remember is that we need to focus on treating the core body temperature because there's certain things that we've all probably seen or been taught throughout our veterinary careers that actually can be counterintuitive to the treatment of heat stroke because it kind of locks in that core body temperature and allows it to continue to rise. So we'll talk a little bit about that in a moment. So, just a brief overview and review of the mechanisms of heat dissipation in dogs. And I don't mean to focus on our brachycephalics here. It's just we see them very commonly in the South, being a Mississippi state grad. The English Bulldog was our mascot. Obviously, the English Bulldog is common throughout the Southeast and throughout the nation in general. But for our four primary mechanisms of heat dissipation include convection, conduction, radiation, and evaporation. And so convection is like the movement of fluid, or basically it's truly kind of a combination of evaporation of moisture off of the skin as air or water flows over it. So for us, that's where we wet the patient down with room temperature water or cool water in place of fan. And we're allowing that water to evaporate off of their skin. So there's evaporative cooling that's happening, and also the convection of pulling the heat out and moving that cool air over their body. Conduction is heat that's removed by just touching surfaces. So when a dog is placed on a metal exam room table, the heat from their body is actually conducted into the table. So it'll warm that area of the metal exam table, but not necessarily the whole table. And then radiation is kind of just heat that radiates off of their body, just being simply in existence. And so we know that 70% of heat loss in dogs and cats occurs through convection, so that movement of airflow or water, mainly airflow for us, over the body, and then radiant heat, so just expressing off of their body. Now that changes a little bit with heat stress and heat stroke. So one of the things that we see, and this is just a natural compensatory mechanism, is when we start experiencing signs of that heat prostration, we do see a vasodilation. So kind of a peripheral vasodilation as a mechanism to bring heat to the surface of the body. So again, getting rid of that core rise in temperature, shunting blood to the periphery so that we can allow that convection and radiation heat dissipation to happen. And so this is unfortunately the opposite of what needs to happen for a patient that is experiencing signs of circulatory shock. So when we talk about compensatory shock, we're all familiar of seeing that patient that comes in and they're experiencing compensatory shock where they're tachycardic, they're vasoconstricted, they're shunting their blood toward their core and vital organs to maintain vital organ perfusion. And that patient comes in and they've got kind of pale to even sometimes white mucous membranes. Their extremity is cold because they're really shunting that blood internally. And so the opposite happens here. If now we're shunting blood externally to the periphery, trying to dissipate heat, but unfortunately that comes at a detriment to the cardiovascular system. So ultimately what we see is there's a decrease in venous return because there's now this huge increase in venous capacitance at the periphery because of blood pooling, and that ultimately reduces our preload and then reduces our cardiac output. And as you can imagine, when we see reduces in cardiac output, we see compromise or decreased blood flow to the gastrointestinal tract, to the kidneys, and ultimately, as we're also familiar with, the shock organ in the dog being the gastrointestinal tract is one of the first things that we see. And actually, one of the first things I asked my sister last night, I was like, is he having bloody diarrhea yet? And so we see that shock organ, so the acute gastroenteritis and sometimes hemorrhagic type of gastroenteritis we see as a first onset sign for heat stress and heat stroke. So evaporation becomes very important, and this also applies to us here a little bit in the southeast. We'll touch on humidity, but evaporation becomes important when the ambient temperature is equal to or greater than the body temperature. So this is where we see, unfortunately, we see mitigations in conduction, convection, and radiation. We really try to use that evaporative cooling. In dogs, their mechanism for that is panting. So when a dog is panting, it's trying to evaporatively cool, and there's partly a little bit of convection that happens. So as they move large volumes of air through their airways from panting, so panting and respiration, obviously it's not true ventilation, but as they're moving these large volumes of air across their airways, they're using evaporative and convective cooling to try and dissipate the heat. So, when you were doing client education, we talked to them about panting as that first cardinal sign, even before the muscle cramps, of potentially heat stress. And the early signs of heat stroke is when, especially when we talk about exertional heat stress, they just start panting first, and that's the first thing to watch out for. I mentioned here in the southeast, and reason I bring this up is the humidity. So the heat index and the humidity play a factor in because humidity mitigates some of that evaporative cooling mechanisms. And so we, again, commonality of our brachycephalic breeds, but in general in the southeast, we do have to worry, and whether that's English bulldogs or older Labrador retrievers that are on the verge of having their first onset of like a clinical episode of laryngeal paralysis, upper airway obstructions, masses, foreign bodies, those types of things. The southeast, unfortunately, adds a little bit of an extra layer to that because of the humidity that we exist in can actually dissipate that. And so these humid environments really kind of add an extra layer of complexity to treating heat stress and heat stroke, because that one mechanism that animals have of evaporative cooling or panting when they sense they are experiencing heat stress, humidity kind of takes that away from them, and so they now don't have that ability. And so the brachycephalic dog we admitted earlier today was quite hyperthermic, but also experiencing almost signs of an upper airway obstruction. And it's that chicken and egg scenario for us. Was this a patient that started experiencing heat stress, became kind of a little bit stressed out, started breathing and panting faster, and then irritated its airways, started to get some airway swelling, kind of vicious cycle of respiratory dyspnea and distress, and now has occluded its airway and is also hyperthermic. Hard to say in those scenarios, but unfortunately, we commonly see that duo on our clinic floor, especially in the emergency room. And so, things to keep in mind, obviously, we're very well aware of brachycephalics, but we also know this is the season now we're about to diagnose all those subclinical LARPAR dogs and laryngeal paralysis cases that have been quiet over the winter months where it was cooler. Also, our tracheal collapse patients that have been asymptomatic over the cooler months, and then airway mass effects. So, things that are less common, like slow growing masses that have exceeded kind of a critical point of where they now are occluding the airway. So, our three protective mechanisms when we talk about management of heat stress and heat stroke, one is thermoregulation. So, we've discussed thus far the kind of innate mechanisms that animals, particularly dogs, have as far as thermoregulation, that evaporative cooling mechanism for them to regulate their own body temperature. And then, unfortunately, the acute phase response that ensues, so that surge response we touched on, and then the expression of intracellular heat shock proteins as to defend against the intracellular damage from heat stress. So, unfortunately, heat stroke has no bias and no preference for any particular organ, and it doesn't differentiate. As we have talked thus far, it does have its effects on the cardiovascular system, or detrimental effects of countering that normal compensatory shock mechanism, where now we're experiencing a kind of a distributive shock of where we're redistributing that blood flow to the periphery, and we're not shunting it to the core to maintain vital organ perfusion. And ultimately, that does result in, well, typically it's pre-renal azotemia in the beginning due to hypovolemia, but ultimately we can see AKI, and then central nervous system dysfunction, as we talked about, the encephalopathy that predominates. And then, unfortunately, inflammation and coagulation, they are best friends. They parallel one another. And so as we start to see activation of the or the inflammatory cascade, so as inflammation is ramping up, so is the coagulation cascade. And so we start to see thromboembolic events, and then we ultimately, and we'll talk a little bit about this later, can see DIC, or disseminated intravascular coagulation. And then there's also the pulmonary effects. So particularly patients like the one here with our brachycephalics, and actually the dog we admitted earlier, when we have acute respiratory distress, where we have heat stress and then ultimately heat stroke, where we do see a combination with an upper airway obstruction, we also can see non-cardiogenic pulmonary edema, and that dog had it radiographically apparent already, even on presentation today. One of the things I talked to my sister about last night is was concern her dog had vomited just the moment he came back inside, and I had kind of talked to her through the potential for aspiration. So there are some pulmonary effects that can also happen that can have some pretty significant sequelae. So a little bit of the pathophys behind things, as we talked, 70% of the heat loss in dogs is through radiation and convection, but that's blunted by this kind of vasodilatory response to dissipate heat. Now we're shunting blood away from our vital organs, we're putting it to the periphery. We're trying to, have this evaporative cooling mechanism by panting, but unfortunately that gets overwhelmed, especially when we're in a humid environment. And then ultimately, our body temperature starts to rise, and it rises to a critical level that obviously is a huge detriment to the patient. We were talking about this actually in the office earlier, but I usually get really concerned once they get above 106. This dog that just presented a few moments ago was 105.9 on presentation. Above 109, I get really concerned about permanent brain damage, and we were just having a fireside chat, and 111 is actually the warmest patient I've ever seen that was physically alive on presentation. So a little bit more of the pathophys, heat shock proteins, and this is something that we don't often think of clinically, but this is part of that acute phase response. Just to dive a little bit more into the pathophysiology of heat stroke, these are made at the point of kind of recognition of heat stress and heat stroke, and it's really to try and dampen down or prevent DNA damage at the cellular level. And when we talk about that, it's mainly like brain damage, because we can see cellular death and then apoptosis. The other part that these do kind of have a more clinical relevance for is the mediation of the baroreceptor response. And so, as we see the patient become hypotensive, the lack of stretch within the baroreceptors is what incites that kind of normal adrenal response to incite tachycardia, and then the vasoconstriction, and then ultimately down the road, activation of the RAS system to retain sodium, retain water, and restore volume and preload. But it does mediate part of that baroreceptor response, where we start to see increases in heart rate and trying to increase cardiac output, because we see those reductions in cardiac output because our preload is diminished from that vasodilation. They also can play an important role in preventing the absorption of endotoxins. So we do see, unfortunately, we should mention earlier that the gastrointestinal tract is the shock organ in the dog. And so unfortunately, when we see these hemorrhagic diarrhea cases come in that are experiencing heat stress or heat stroke, because there is an increase in the permeability of the gastrointestinal tract, there is a high risk, and there's some bacteremia and high risk for sepsis. And so heat shock proteins can help play into that as well, and help prevent some of the activation of leukocytes and then the activation of those endothelial cells, as we talk about, like activation of the inflammatory cascade as well as activation of the coagulation cascade. This is just a little bit of what heat shock proteins do for those that are curious. Again, not the first thing we think of clinically when we're treating heat stress and heat stroke, but just to kind of give you a little bit of the background of how they actually work and what they do as far as modifications at the cellular level. So again, a little bit more of the pathophys. Unfortunately, once we start to activate the coagulation system, what we see is we see DIC develop very quickly in these cases. And so DIC I often will describe as a thrombohemorrhagic syndrome, because it's kind of a reverse bell curve. And I think I have a slide in just a moment that kind of depicts that. But what we see with activation and the kind of development of DIC is there's an initial hypercoagulation that happens, or hypercoagulable phase that happens, where we are consuming our clotting factors, we are consuming our platelets. And then ultimately, we go into this hypocoagulopathic phase of where we are now seeing petechia ecchymoses from thrombocytopenia, as well as clinical bleeding from depletion of clotting factors. And then we also see this inhibition of fibrinolysis. So, the one kind of mechanism we have for stabilizing our blood clots, now we're losing that, and those clots that we do form will break them down much faster than we normally would. And so, therefore, we're having all of this clotting happening, then we can't clot. And then when we do clot, we can't maintain those blood clots. Um, and so, we see this with any kind of pro-inflammatory phase can develop with DIC. Obviously, you're very familiar with that, but we see it specifically with heat stress. And unfortunately, this development of DIC a lot of times is what contributes to the multi-organ dysfunction syndrome that we see with heat stress and heat stroke. This is just a picture, obviously. So this is a patient that presented for heat stress and heat stroke that had we think had aspirated, but had developed some pulmonary edema as well. This patient was placed immediately in an oxygen cage, and you can see here these are just your cardinal clinical signs of the multi-organ dysfunction syndrome that we see associated with heat stress and heat stroke. This is a patient that's now got fluid coming out of its airways, so clear kind of yellow discolored fluid. You can also see from the venipuncture sites where we were attempting to get catheters in this patient, there's clinical bleeding, and then also it is having copious amounts of just hemorrhagic to even brown discolored diarrhea. So this is unfortunately the end stages of multi-organ dysfunction syndrome associated with heat stress and heat stroke, but we're all too familiar with seeing cases like this. The other thing that I commonly will school people on, this is a little bit of my background. Way back in the day, I was a bit of a marathon runner and triathlete. And it's very common that we see people that want to get out and take their dog for a run. And they've been doing that in the spring months. So late February, especially here in the Southeast, late February, March, April, that's okay. And as we start to get into May, June, and July, they kind of expect well, let me just go out. We're going to go for a run. We've been doing 2 miles or 1 mile or whatever. Recently they continue to keep up that normal regimen, and then we'll see those patients come in because now they have gone out for a run, the humidity was up and changed that day, the temperature was up that day, and then all of a sudden we have a patient that's experiencing heat stress and heat stroke. And so one of the things that I used to do outside of kind of the interconnections of the vet world and is in my running groups and things like that, educate people on this is how to properly run with your dog, and this is things to consider. So this also can play into client education as well if you've got clients who do a lot of activities with their pets. So as we mentioned earlier, kind of early warning signs would be the excessive panting, that mechanism of evaporative cooling, things to watch for. I always tell them, like, yeah, if you normally walk 2 blocks and you see they're starting to lag behind, that's the first sign that they're kind of like fatiguing a little bit. They maybe want to take a break, so stop and rest. And particularly with our brachycephalics, the stridus or stridus breathing, as we're all too familiar with, when they start to get a little bit loud in those breathing efforts, then we really get a little bit worried because we know that it's that vicious cycle we talked about earlier, where we start to see them occlude their airway, they get non-cardiogenic pulmonary edema, they have no way to ventilate, and they have no way to get the heat off, and so they can't dissipate their heat. They get hotter, they try to breathe faster. It's just a vicious cycle. So looking at these heat stress, heat stroke patients, interestingly enough, their temperature on presentation can be increased, decreased, and/or normal. My sister last night when she called me had actually done the appropriate measures. They had doused him in water. They had put him in front of a box fan, and her pup was actually 101.7 by the time she called me. And we'll talk about like cooling mechanisms and kind of what temperatures to watch for. But when she called, I was like, okay, sounds good. So stop. So stop the fan. Let's back up for just a second. But they can be all over the place. There are pulses. They're typically tachycardic. This is that compensatory shock mechanism. So this is where they're tachycardic. They're trying to shunt their blood flow. But sometimes if they're going into the end stages, they can be bradycardic. And often, obviously, they're panting, trying to get that heat dissipation off. But they can have any signs of overt, true respiratory distress. So true attempts to increase their ventilation, whether it's purely just to get the temperature down and blow off the hyperthermia, or unfortunately, if we're seeing signs of aspiration, non-cardiogenic pulmonary edema, or pulmonary hemorrhage from exertion. Mentation, again, we focus a lot on encephalopathy when we're dealing with heat stress and heat stroke patients, just because when we go way back to kind of the cellular DNA damage and irreversible cellular damage, we focus a lot on the brain. And serial monitoring of mentation, as we'll talk about in a minute, it becomes very important. And so a lot of times these patients are pretty comatose to very depressed on presentation. And in fact, the little pup that just presented right before this talk here was very depressed, almost comatose on presentation. And I kept checking in on him. And over the course of about 45 minutes with some active cooling, he was able to actually be a little bit more with it, a little bit interactive and reactive. Actually, interestingly enough, is showing some signs of possible cortical blindness right now, but that may be a reversible change once we restore CNS perfusion. But one of the things we'll talk about in a second is kind of serially looking at their mentation and Glasgow coma scales. And worsening mentation, as you can imagine, is associated with a poor prognosis. And so this can help you to trend things over time and make some kind of educated discussions with the owners about prognosis and then further, treatments. Another focus for us is the gastrointestinal tract, and this was almost a little bit of a comical discussion with my sister last night because they live in very rural Mississippi where it's at least 2 to 3 hours from the nearest emergency vet hospital. And so I started asking her, I was like, what GI meds do you have in your house right now? Because I kind of warned her that the hemorrhagic diarrhea is probably coming if it hasn't already. And my main concern would be bacteremia, endotoxemia, and the potential for septic shock if he has kind of gone into fulminant heat stroke. So we focus a lot on the GI tract and treatment of the GI tract, not only because it's kind of one of the first clinical signs that we see with heat stress and heat stroke, but also from the repercussions of bacteremia. Things that we see on blood work, a lot of times we'll see hemoconcentration, not always, but we can definitely see it. One of the things that we know from the literature that we can use to prognosticate is kind of that stress response that causes the bone marrow to kick out nucleated red blood cells. So that kind of jolt to the bone marrow when they start to kick out these nucleated red cells, that has been so associated with more poor outcome and a worse prognosis. About 18 per 100 is what's cited in the literature. But if you start to see, I think I have it on this next slide here. Yep. So if you do a blood smear even and you start to see these nucleated red blood cells, that can be a poor prognostic indicator for these patients because it kind of leads to the level of stress the patient has been put under and kind of the degree of injury that the body has seen. And so this can be one more factor when we talk about serial monitoring of mentation and Glasgow coma scales, looking clinical pathologically at just a blood smear can tell you a little bit more to be, more honest with the owners about what the prognosis for this patient might be. So, kind of the take-home key point for this, and I touched base with one of my previous residents. I always like keeping in touch with my residents because they keep me up to speed on things. It's good to have those connections. She focuses a lot in the area of heat stress and heat stroke. In my prior time in academia, I actually worked a little bit with the military, doing some research projects with heat stress and heat stroke in dogs. She's maintained some of those connections. And there's no one cooling method that has been proven superior to another. So there's nothing, when we look at human literature, veterinary literature studies, there's nothing that has been proven like this is the one treatment you have to explicitly do that changes outcome and they live or they die with this or not. Unfortunately, like a lot of veterinary medicine, it is a gray zone and we don't have a lot of research to support some of the things that we do. When we go back, kind of looking at our primary mechanisms for heat dissipation, particularly in dogs, we focus on evaporative cooling, convective cooling, and these are things that are also just from in my experience, wetting the body down with either cool water or room temperature water and putting a fan blowing over them is probably one of the most commonly utilized methods that I see in practice. I see it work quite well. Extreme cooling, so like an ice bath, is not recommended. So when we talk about the compensatory shock mechanisms that we see and then that vasodilatory response where we shunt blood to the periphery to get the temperature, the core temperature down. This is where we can actually be a detriment to our patients if we decide to be a little bit aggressive with our cooling and put them in an ice bath. So what happens is if we put them in an ice bath, we actually cause peripheral vasoconstriction, which causes a paradoxical rise or heat trapping of the core body temperature. And so the tricky part of that is it causes such intense peripheral vasoconstriction that if you were to take a peripheral temperature, you may get a value that is normal or hypothermic, but in fact, their core body temperature is actually rising and could be much, much higher. And so we don't recommend typically putting them in an ice bath. Obviously, we've all seen it or done it. Wetting the foot pads with alcohol seems to be a common practice. There's been no research really there to look at that. Wetting the entire patient with alcohol obviously can be quite noxious as far as like just the odor to a patient. So we don't recommend doing that. And obviously, in the event of cardiac arrest, and you would need to do cardiac or defibrillation, then the risk for ignition is pretty high. And so it's not recommended to fully douse them in alcohol, but we do still see the foot pads utilized in that sense. I think I have them, yep, here on the next slide. So some people think that this is a futile effort because they think that the wetting of the foot pads, the primary mechanism with the alcohol is truly evaporative cooling. And they think that dogs can technically theoretically sweat through their foot pads. And so they think that the real estate though for heat dissipation is so small with the foot pads that it may not be of clinical significance. But in those situations, especially like a dog we have on the table earlier, where they're about 106 or so, for me, any additional help as far as getting that temperature down is helpful. So, in addition to some of those other methods, I still will consider it. But there's been no literature out there to actually evaluate whether it is or isn't helpful. So those are all external cooling methods. So the wetting them down, placing a fan on them. Some people will put ice packs next to them instead of putting them in an ice bath. There are also internal cooling methods, and I'll be quite honest, I've actually never done any of these in my career. I've never had to, mainly because some of them are fairly invasive and they also come with pretty significant risks. So gastric lavage with ice water is discussed. For me, doing gastric lavage is something that has a high risk of aspiration, and these patients are already primed or predisposed to aspiration. So I typically don't recommend it or I don't do it in clinical practice. Iced peritoneal lavage is also discussed. Obviously, there's a risk of septic peritonitis and those types of things. So I don't usually consider that. Cold water enemas could be a fairly benign thing to consider, but I've never had to do those. Again, when we weigh the risk versus benefit ratio and the complications of some of these internal cooling methods, that would be the reasons I think they're not commonly employed. Dantrolene, so if we talk about a pharmacologic mechanism for treatment of hyperthermia, this is a drug that's actually been looked at, obviously, to treat malignant hyperthermia in greyhounds. It's a ryanodine receptor blocker for muscle contraction. So when we talk about those muscle fasciculations and muscle contracture that actually contribute to the development or the perpetuation of hyperthermia. I've also never used it clinically for the treatment of heat stress or heat stroke, but it is something from a pharmacologic perspective that can be considered. So again, kind of take homes for heat treatment of heat stroke is that there's no one technique that is superior to the other. When we talk about getting their temperature down, so like we're presented with this dog here today that's 105.9, 106, we want to reduce that temperature at about 0.3 to 0.4 degrees Fahrenheit per minute. And so trying to get it down steadily over time, and you can do full body wetting. There's also discussion of like using an ice cube in like a Ziploc bag that's rubbed over the muscles to help to loosen the muscles up to prevent muscle kind of like spasms, but also with cooling. But again, most of the time I will just wet them down and then place a fan blowing over their body to allow that a convective mechanism to work. And I find that that's quite efficacious. One thing, this is where I stopped my sister last night. So when we were looking at cooling measures, we want to stop when we get their temperature down to 103. So we know that 102.5 is typically the upper limit of normal for a dog for their normal reference range. And so we want to get them just almost back down to normal, but not within that normal reference range. And the reason for that is we can have kind of an overshoot effect and we can get this rebound hypothermia. We do know that they lose the ability to kind of auto regulate their temperature for a while after they've experienced heat stress or heat stroke. So we really want to stop at that like 103 mark and not actively cool them any further because we could actually put them into more of a hypothermic crisis rather than hyperthermic. Um, and it's really not unusual, as I mentioned here. I have seen dogs that they lose that ability to thermoregulate, and we get them down from 106, 107. We stop cooling at 103. We think we're at 101. Things are looking quite better. Things are fine, and then an hour or two later, they're sitting at 95 degrees. So continuous serial monitoring of these guys is critical, and that's part of the hard part of our discussion is trying to get owners to hospitalize for continued monitoring and supportive care because what they don't realize is we're temping them hourly to even more frequently. We're watching their losses, we're assessing their mutations, so all of those things play into effect. So as far as resuscitation goes, volume expansion is very helpful, especially room temperature fluids. So fluids that are at room temp 70 or degrees or whatever. You can do rapid volume expansion, and also that provides core body temperature reduction. And so we're historically taught, and this is obviously not a talk on fluid therapy, so I won't go on too far of a tangent, but when we talk about shock volumes in dogs, there many years ago, we looked at giving entire blood volumes almost of dogs to them on presentation in the ER setting, and then we talked a little bit more about halves and then quarter aliquots of those shock volumes. And we have to keep in mind that there are many beneficial effects of crystalloid therapy in these patients for cooling and then volume restoration, but we also have to think about the downsides as well. One thing to consider, especially with these guys, knowing that they're kind of on the verge or at the predisposition of developing DIC and having a underlying kind of pathophysiologic coagulopathy, we also have to keep in mind that with the amount of fluids that we give, we can also cause a dilutional coagulopathy. So we can dilute out what little clotting factors they have left and actually perpetuate their clinical bleeding. And so for these guys, I'm usually a little bit more conservative where I'll start with a quarter shock and then maybe go up to a half and then start thinking about other options for volume support. And then, as I mentioned here at the last bullet point, for some of these patients that can't be stabilized with volume support, we may have to consider vasopressor therapy. Now, obviously, the implementation of vasopressor therapy in these guys usually is associated with a poor or worse prognosis and outcome because they can't maintain their blood pressure without that extra support. So other things that we can see typically, or we can see hypoglycemia fairly commonly. So symptomatic treatment with a dextrose bolus and or the addition of dextrose to the fluids. We talked earlier about encephalopathy usually predominates with the syndrome of heat stress or heat stroke. So we're monitoring for signs of further depression. Are they comatose? Are they stuporous? And then really looking at these serial coma scale scores. So I think I have it here. Yeah. So this is just a typical chart that we're all familiar with, where the modified Glasgow coma scale. And so I don't usually kind of like the way we practice with a lot of things. I don't hang my hat on one typical exam as well as one number. I will serially trend this over time. And so trends in our Glasgow coma scale. So for example, if I'm having a patient assessed, if I'm looking at them every 4 to 6 hours on the overnight, having someone take a look at them about every 4 hours or so, if I see negative trends in that coma scale, then I'm going to make some kind of more prognostic decisions or calls or have some honest discussions with the owner about outcomes. And so trending your coma scale score over time or just trending their mentation over time is quite helpful so that we know are they improving or are things kind of looking worse. And so this is something that I also would provide kind of as a laminated card in the ICU setting or in the ER setting to kind of get a baseline coma scale when they come in, and then also to trend on their overnight coma scales. This is a dog that we actually were doing a bear test, so brain auditory electrical response test. So this is something else you can do if you're in a more advanced setting. This is a neurologic test to actually test for brain activity. So if you have a patient that is overtly comatose or obtunded, this is one of the things that we can look at to see if they have any brain activity left, but obviously kind of an advanced type of diagnostic. So monitoring for our patients, so if we're getting them resuscitated, things we want to watch out for, want to maintain an adequate urine output, so at least a minimum of 1 to 2 mils per kg per hour of urine output. Very commonly, these guys are coming in and they're already dehydrated. They've got every reason in the world to have prerenal azotemia. They're hypovolemic from all their gastrointestinal losses. And so it's very common for them to have a physiologic oliguria or physiologic anuria in the beginning phases. But once we've adequately resuscitated them and we've kind of gotten the tank full and restored all that volume depletion, we should start to see normal numbers as far as urine output goes. And so if we're not seeing normal urine output and we're seeing gains in body weight, we're seeing the patient now unfortunately start to look overhydrated with our fluid therapy plan, but they're not producing urine and the bladder seems empty on an ultrasound, then we worry about acute kidney injury and possibly acute renal failure. We also watch their respiratory rate, effort, and then we look at their oxygenation. So whether that be either through arterial blood gas versus pulse oximetry. And the main reason is things we've already discussed. So concern for non-cardiogenic pulmonary edema, aspiration, pulmonary hemorrhage, all of those things we watch the respiratory rate and character for. And then coagulation testing would be the other thing. So as we kind of, and I think I have it in a moment, looking at that reverse bell curve, doing your typical coagulation parameters of PT and PTT can be helpful. The limitations of PT and PTT are that they can't really identify hypercoagulability. They're mainly for hypo. And so once the patient tips over into the hypocoagulopathic phase of DIC, we can see changes in our PT and PTT, most often PTT first. But thromboelastography or TEG or a VCM machine, if you're familiar with those, can give you a little bit more of a global picture of coagulation. And so those are machines that they will actually look at overall clot formation, clot strength, and clot breakdown. And when we look at a TEG or a VCM, we can actually assess for both hypercoagulability and hypocoagulability. And so that may be a little bit helpful to catch in the different phases of DIC in contrast to a PT or PTT. As we talked earlier, so a lot of these patients are hypotensive on admission, so vasopressor support may be necessary if volume support wasn't enough. When we talk about the treatment of DIC, and this usually is one of the more controversial topics, DIC in and of itself is a secondary syndrome, but unfortunately the coagulation system has to be considered as its own organ system. So when I'm discussing multi-organ dysfunction syndrome with a client, I kind of isolate the coagulation system as its own organ system or own entity that plays into when we're talking about pulmonary dysfunction, AKI, renal dysfunction, those types of things. And one of the things that we've changed, and this can be institutional via training, it can be just what we know, and as we learn more, the addition of plasma therapy for the treatment of DIC, the recommendations, come and go and they change over time. And depending on the clinician, I'm very much more a pro transfusion person when it comes to plasma. And this just comes from, studying and looking at the human literature as far as plasma is it's iso-oncotic, it's isoosmotic, it has beneficial factors as far as clotting factors. It has albumin, many beneficial things. Now, it's not to say it's a benign therapy in the least. There are things, if leukoreduction is not done when blood products are actually harvested, then you can have, at some point, lysis of leukocytes and then the release of inflammatory cytokines that can sit in plasma and or stored blood. These are all considerations. But the more we learn specifically about the endothelial glycocalyx, which is that lining that lines blood vessels, and the damage that happens to that layer, specifically when we talk about heat stress and heat stroke and that increase in vascular permeability, interestingly enough, people store a quarter of our plasma volume in that glycocalyx layer at any one point in time of the day. And so when we talk about plasma therapy, specifically for restoration of that glycocalyx layer and then prevention of the further leak or that like permeability increase that we see with heat stress and heat stroke, I'm more apt to actually recommend a plasma transfusion for these patients early on, not necessarily just to treat the coagulopathy that I see develop from DIC sometimes, but also to treat the cardiovascular dysfunction that I see because of that damage to the glycocalyx. The other thing to consider, and this is more of the later phases, when we see the surge response happen and they initially are hyperinflammatory and hypercoagulopathic, we often miss that sometimes. There's a very short phase, and then what we see clinically is the hypocoagulopathic events, and where they're clinically bleeding. But if they recover, we actually can see an uptick or a spike up where they become hyperinflammatory once again, and then ultimately hypercoagulopathic. So that's a window of time where sometimes we have to consider anticoagulating these patients to prevent further or to prevent thromboembolic events. And then GI hypoperfusion, as we've discussed earlier, being the shock organ, is super important to be aware of. And so gastroprotection is of the utmost importance. And this is where I had my sister digging through her medicine cabinet last night to see what meds she actually had. I'm like, do you have Prilosec? Let's talk. And so seeing what she had on hand, because knowing that gastroprotection, prevention of ulcers, and anything we could do for that dog in the moment was going to be helpful, trying to be and get on top of that kind of GI distress that I felt was probably coming. Here we go. Mentioned this earlier. So this is how I kind of pictorially describe the phases of DIC. So as you can see here on the hypercoagulable phase side, in the beginning, those are where you typically see the inflammatory cascade kind of ramp up. So that initial surge response. So we see this hyperinflammatory phase where the patient is hypercoagulopathic, and then they dive down. The first sign we usually see with DIC is a thrombocytopenia on our blood work. And that'll happen even more so before we see prolongations in our clotting times. We'll see that DIC start to develop mild to moderate thrombocytopenia, not anything like a typical ITP, so not in the single digits. But then they develop this hypocoagulopathy, where now they have depleted their platelets, now they're depleting their clotting factors, and they're in that low swing of the reverse bell curve you see here. So on the lower end of the roller coaster, where they're truly hypocoagulopathic, and unfortunately, this is where we lose a lot of patients because they get into that kind of lethal triad window and they have an acidosis and hypocoagulability and all the things, and then we lose them. And then the upswing over here is where if we have a patient that recovers, and this is not specifically to heat stroke, if they're recovering from DIC for all causes, we can see this kind of hyperinflammatory, and it's a robust, like positive response that the bone marrow is saying, we want to live, we're going to kick out red blood cells, we're going to kick out white blood cells, we're going to do all the things, kick out more platelets, but they do intrinsically become hypercoagulopathic. And so this is that window where we may have to consider anticoagulating a patient because of that uptick in the recovery from DIC. So vasopressor support. So again, if our volume resuscitation is not enough, so volume hypotension that's not responsive to fluid resuscitation, this is that inflammatory surge response, and it's typically due to inappropriate vasomotor tone at that point. And this is where it's hard to really dissect these cases because, as we mentioned in the very beginning of our talk, a lot of these patients are going to come in and have a peripheral vasodilation as a mechanism for evaporative cooling, and they're trying to push blood to the periphery so they can get that heat off. And so, by definition, that is a type of distributive shock where you have inappropriate vasomotor tone for the degree of shock the patient is actually experiencing. And that also can happen here where you have inappropriate vasomotor tone and you're going into truly septic shock. So that's one of the mechanisms of how the inflammatory cytokines actually inhibit normal vasomotor tone. And so these guys are kind of hard. And so in the beginning phases, when you see this case where you think like, they're really vasodilated and they shouldn't be, trying that volume resuscitation first would be the first step. And then vasopressor therapy should be one of the kind of tail end things we consider as far as resuscitation goes, because if we reverse that and we do vasopressor support in the beginning without adequate volume resuscitation, we actually compromise our patients where we will vasoconstrict them to the point that they're hypoperfused. And so we should always try to resuscitate them with fluids first before we actually implement vasopressor support. So for vasopressors for these guys, norepinephrine or dopamine are typically your first line. So you're looking at both pure vasoconstrictors or vasoconstriction to decrease that venous capacitance to shunt the blood back toward the core. You're also looking for a little bit of positive inotropic support. And so either of those are appropriate. And I just put some doses here for prescribed CRIs just for curiosity, but just put some doses in there. So one important thing about vasopressor therapy, if you do have to employ vasopressors for support, and this is not just, again, intrinsic to heat stroke, but anytime you have a patient that's on a norepi CRI or a dopamine CRI, never cold turkey discontinue the vasopressor. It's one of the most common mistakes I've seen in my career. Is we're very proud of ourselves, and we've implemented a vasopressor, and the patient's blood pressure is now normal. They're looking good. Things look great. Let's turn it off and let's go on. And patients have to be weaned off of these vasopressors because of the dependence that they have. And so what we have to do is slowly desaturate their receptors for the dependence upon a catecholamine. And so if we have norepi and we're at 0.5, then I usually say, let's come down in increments of 0.1 or from 0.5 to 0.3 to 0.1 before we wean them off. Because if we gradually wean them off, then we can avoid the rebound hypotension that happens from that acute kind of circulatory shock or decrease in vasomotor tone. And then we have much more likely of a chance of getting that patient off vasopressors permanently and then ultimately, hopefully, out of the hospital. Arrhythmias are the other thing that we can see. And so, as we know, there are many reasons to see ventricular arrhythmias, like we see with ventricular tachycardia here. And so, pain, hypoxemia, hypovolemia is the big one. But just the myocardial hypoperfusion in these guys, it's very common that we do see some ventricular arrhythmias. Now, we may see things that are like singlets or couplets or just a small short run of BPCs that may not warrant overt immediate clinical intervention. But when we start to see signs where we have sustained runs, rates greater than 160, they're hemodynamically significant, we see RLT phenomenon, those are all reasons that we would want to treat them. And so we just typically employ our common antiarrhythmic therapies. So we're all familiar with using lidocaine for immediate treatment, so initial bolus of 2 mg per kg, and then considering a CRI. One of the things that's commonly overlooked with a lidocaine CRI is their dose range has different effects. And so when we talk about using a lidocaine CRI for like an analgesic effect, that's typically in the range of 20 to 30 micrograms per kilogram per minute. And really to achieve the antiarrhythmic effect from a lidocaine CRI, we really need to be above 50. So most people will put their antiarrhythmic CRIs in the range of 50 to 75. I've even seen as high as 80 micrograms per kilogram per minute. But the one thing to remember, especially with these higher doses of lidocaine as a CRI, these guys are already primed for gastrointestinal dysfunction. And again, we've talked about the importance of gastroprotection and focus on the GI tract. That dose of lidocaine will make them incredibly nauseous. And so you can see excessive tylism, and then also kind of they'll be a little bit hesitant to eat. Their appetite will be diminished. And sometimes it's specifically more of a pharmacologic anorexia or hyporexia rather than them actually not wanting to eat. And so employing all the gastroprotection and trying to support their GI tract is very important, but also remembering that some of the reason they may not be eating may be something that we're doing to treat other problems they may be having. So again, just talked about this, got ahead of myself there. So again, lower doses predominantly for an analgesic effect, whereas the higher doses are antiarrhythmic. Other things that can be considered, so if you are dealing with refractory arrhythmias, you can consider esmolol. Some people, I don't think that we stock that in our pharmacy here. Many don't, just due to its expense, but beta blockers can also be your friend. And so, even if you don't have IV versions of like the beta blockers, if you have a patient that is experiencing significant arrhythmias and lidocaine is not necessarily working, or you have procainamide and procainamide is not necessarily taking care of things, you can also consider oral beta blockers such as sotalol. Those types of things also work quite well. One thing that I've kind of cautioned, especially teaching a lot of interns and residents, is when I get a phone call, especially middle of the night or on the weekend, and I get a description of, oh my gosh, they're having VTAC or they're having ventricular arrhythmias, is to really kind of discern, is it truly ventricular tachycardia and a ventricular rhythm that is of concern, or is it more of a ventricular escape? We all are familiar with seeing the accelerated idioventricular rhythm with a post-op splenectomy that we commonly happens post-op. We sometimes see this rhythm here we have on the screen, so an escape rhythm, which is a ventricular escape rhythm that's suprabradycardic. Those are life-saving. And so we never want to misconstrue like a ventricular rhythm, particularly an escape rhythm that's that bradycardic. And typically those guys are in the range of like 30 to 40 beats per minute with a true quote ventricular rhythm and treat with lidocaine, because unfortunately if we were to use lidocaine to actually block the escape rhythm, that could actually end the patient. And so always asking like, what's the rate? Is it greater than 160? Is it greater than 180? Is it sustained? Do you see RNT phenomenons? Is it multiform? Do you think that it's on the verge of VFib? Those are all great questions to ask yourself. Again, plasma therapy is something that I'm more pro for, but again, can be a controversial topic. So fresh frozen plasma, isooncotic, isoosmotic, contains albumin clotting factors. We discussed that. I'm more of a fan of it because it does protect and restore that endothelial glycocalyx layer damage that we see in the blood vessels, especially that increase in vascular permeability. I apologize, look at time, it's 8:01, so I'll try to get through the rest of this. So I'm very much a fan of plasma when it comes to these guys. Gastroprotection, again, we talked a little bit about the prophylactic treatment for ulcers, and then antimicrobial therapy for the concern of bacteremia, endotoxemia, and bacterial translocation. I'll typically go with something broad spectrum, so something like Unison to start with. And then again, the gastroprotection, so pantoprazole, omeprazole, the proton pump inhibitors, and the acid reducers just to help prevent some of those ulcers. More supportive care things we discussed earlier. So dextrose, getting dextrose added to the fluid if they are hypoglycemic. One thing as well. So typically we'll do 5% dextrose as a dilution in their fluids through a peripheral catheter. But if you do have to go higher than that, keeping in mind that higher concentrations or percentage of dextrose ideally go through a jugular catheter just to avoid vasculitis. And then fluid balance. Very, very important here as we talked. So adequate volume resuscitation is cornerstone here, starting with isotonic crystalloids, and then whether you consider hypertonic saline. The topic of head-of-starch can be its own hour-long discussion in and of itself these days. But providing adequate fluid resuscitation, but avoiding fluid overload. And this is where we kind of reflect back to that 90 ml per kg historical bolus of not jumping in with too many crystalloids, not only from a dilutional coagulopathy perspective, but just fluid overload in general. I always say you can add more, but you can't take back. And so continual reassessment of our patients when we're doing this aggressive volume resuscitation is super important. One of the studies I actually will commonly reference is actually from a friend of mine that published this out of, it's actually a collaborative study out of Colorado State and North Carolina State, looking at fluid overload and its relationship in critically ill dogs. And one of the things that we're starting to see is that a positive fluid balance actually does have a detrimental effect on our patients. And what she actually found was the fluid overload during hospitalization was associated with increased morbidity and mortality. And so more fluids are not always better in these cases. And so that's why I say it is important to resuscitate them. But when you have a patient that is hypotensive, that is not responsive to fluid resuscitation, vasopressor therapy should be considered rather than continuing to volume load them, because we can actually put them into a crisis situation. Try to get through the last couple of these. I put some things in here, and I'm happy to answer questions on any of these, but I just want to make sure we get through this in a timely manner and respect your time. Just put some calculations in here for calculating fluid therapy for what typically we do across, practice with multiple equations. Again, prevention of heat stress and heat stroke. These are all common things that we know as far as educating clients, talking to them about, environmental aspects of things. But again, more client education stuff. And then talking about prognosis. So we talked about serial classical coma scales. We talked about the need for vasopressor support despite volume resuscitation and to treat hypotension. Patients that develop multi-organ dysfunction syndrome. So multi-organ or MODS in and of itself carries about a 75% mortality rate. So unfortunately, these guys have the odds stacked against them right out the gate when we talk about MODS from heat stroke. This was a kind of a retrospective, an older study looking at the mortality rate. So mortality rate was 50% overall. So, and then they looked at some of the parameters that were associated specifically with survival. So things that were associated with death on admission for dogs was hypoglycemia and if they were coagulopathic. And also if they had evidence of potential AKI, obviously it'd be intuitive that delayed admission from heat stress or heat stroke would be a detriment to their survival, and then the onset of seizures, and then contributing factor and also outcome would be obesity. Again, prognosis, looking at these guys, if they develop hypoglycemia, hypocholesterolemia, all of the kind of clinical pathologic parameters that show multi-organ dysfunction. We touched on some of the ventricular arrhythmias and the development of those just from myocardial oxygen demands and dysfunction, but also can see that with thromboembolic events as we throw microthrombi to the myocardium, azotemia and AKI. Obesity, again, we just discussed some of these things, but they all can contribute, and factors that play into the discussion for prognosis and obviously the commitment of the client to treat a case that comes in with severe heat stress and heat stroke. All right, 5 minutes over. I sincerely apologize for that. So I'll turn it over to Dr. Harrington if she has any questions or anything backed up for us, and I'm happy to answer any questions or discuss anything.
This is great. Thank you so much. And as we know, summer is coming and these cases are going to start coming in very shortly. We have several good questions here. I'll start off with, which I've done this, so I'm interested to know what your response is. What about infusion of the urinary bladder with cooled saline for core cooling?
I've never done that clinically. Along with gastric lavage, that is a method that is discussed and it is documented I think it's actually documented in the literature. But I've never actually done it, mainly because if you have a case that's presenting on an emergency basis, most people, for male dogs, it's easier to place a red rubber urinary catheter, and that can be employed. Female urinary catheters are a little bit more complex to place for some people. And so just because a lot of the efforts are actually focused on attaining venous access, fluid resuscitation, and then the evaporative cooling mechanisms of wetting the patient down, putting a fan on them, and depending on how many hands you have on deck, what I find is typically there's not enough hands to place a urinary catheter and employ a lot of the internal cooling methods. And so that's why things like gastric lavage, urinary bladder infusion, those things aren't done.
Okay. But if you have plenty of hands on one and it's a male
absolutely
dog.
Yes, absolutely can be considered. Absolutely.
Great. Going back to coagulation, how often do we need to check PT, PTT/TEG? What would be your recommended serial rechecks?
So ideally, we would get one as baseline on admission. And so if you can, when you place the IV catheter and you're pulling your initial blood samples to run your blood work, pull for a PT, PTT, or a TEG at that moment. Get a baseline to see where you're starting, and then it depends. Obviously, we have to make a lot of clinical decisions based on finances, and that adds to. We always want to make sure that we're putting their finances toward the betterment and the treatment of the patient and not just the diagnostics. And so I would probably minimally check them every 12 hours unless the patient started to decline. And by decline, I mean, if their PCV started dropping, I saw overt signs of petechiae or ecchymoses, or they developed any cavitary effusions, then I would check them sooner rather than later. But I would probably check them about every 12 hours during the hospitalization just to kind of trend and make sure that we weren't tipping toward the DIC.
Great, thank you. Any guidelines on FFP as a maintenance fluid versus bolus?
That's awesome. I love this topic. Yes. So I was trained in my residency to actually use fresh frozen plasma as a fluid at times when it's needed, rather than bolus therapy. So, kind of the infancy of my training, we used plasma for your rodenticide toxicity case that came in. It got a 10 mil per kick bolus of fresh frozen plasma one time. It's done and over, and then we go on about our way. What I find with when I talk about plasma therapy is that when you're specifically doing plasma therapy to restore the glycocalyx, more of a CRI is beneficial for that continual effect to restore that layer. And so I will actually pull plasma out and thaw it for 4 hour alquats at a time and then use it as a CRI as their fluid. And I've done that for like multiple days in hospital. Now, obviously, that is expensive for some patients. For small patients, it's not, but for bigger patients, that can be cost prohibitive. But I do use it as a fluid at times. And in people, they'll actually use plasma and albumin for resuscitation fluids. So that's more, they talk about it being more physiologic. And when you think about it, and especially the perspective of our heat stroke patients that may develop a dilutional coagulopathy, or potentially with looking at those prognostic studies, be coagulopathic on presentation, it may be beneficial to consider plasma therapy as their fluid, rather than further diluting them out with isotonic crystalloids and all the other effects. So I absolutely will use plasma as a fluid. Now, the reason for the 4 hour window is if plasma is left out at room temperature or hung on a bag or a syringe pump for longer than 4 hours, there is risk for bacterial contamination and overgrowth within the bag. And so having your plasma divided out, so if you thaw it, keep it refrigerated and then pull it out in little aliquots. And then it's a little bit more labor intensive, but refilling a syringe pump, I've definitely done that in the past.
Okay, so this is focusing on horses. With our horse friends, we use a heat index. I guess it's actually back to dogs, but with our horse friends, we use a heat index of heat plus humidity, and we don't ride if it's greater than 180. Is there a similar index for dogs that need to work in the heat?
Not that's published that I'm aware of. There's a sliding scale chart. I would actually have to myself pull it up. It's available online for dogs that looks at exactly that, the heat versus the humidity, and it actually has a more of a line graph. But I'm not sure of myself of a pivotal point that there is for dogs, but I can definitely look it up.
Okay, thank you. Is the temperature decreasing to 95 a poor prognostic indicator?
Hypothermia, in my experience, it's not documented in the literature, is a poor prognostic indicator because they've lost complete thermoregulation. And so they've lost the ability to regulate their own body temperature. And a lot of times that means that they're experiencing other signs of multi organ dysfunction. And so, even though it's not a hard, fast, on paper, poor prognostic indicator, I find that patients that do become hypothermic following aggressive or just normal cooling methods, they don't do as well. I was actually talking to one of our clinicians earlier today. I received a patient that had been unfortunately dunked in an ice bath per the owners prior to presentation, and the temperature ironically did read on admission, and it was 87 degrees. That also is the record for the most hypothermic patient I've ever seen that was alive, but the patient unfortunately went into cardiac arrest almost within minutes of presentation.
Okay, so similar theme. What measures are you taking when a patient's temperature drops low after correcting for heat stroke?
So you can do active warming, but you have to be careful. So these guys are a little bit delicate. So if you think back to a patient that is experiencing circulatory shock or compensatory shock, and they're vasoconstricting because they're pushing blood to their core, and they're doing everything they can to stay alive. And then we start to volume resuscitate them, but we haven't gotten there yet. And then we start aggressively, actively warming them. If we were to vasodilate a patient that we haven't adequately volume resuscitated, we can cause an iatrogenic peripheral vasoconstriction, therefore increasing their venous capacitance, and ultimately induce a circulatory distributive shock by warming them too aggressively. And so for patients that become hypothermic, we can actively warm them to help them maintain thermoregulation, but don't be too aggressive with it. And we have to make sure that we have volume resuscitated them first adequately before we do that. Because the repercussions, if they do fall there, So let's say they get to 95 degrees or they're falling even further. They actually will start shivering and that's a normal physiologic response, as we all know. Like when you get cold, you shiver. And when they start shivering, those muscle fasciculations and muscle tremors can actually start to drive their core temperature up. And depending on where their core temperature is in relation to their external temperature, you actually could drive heat stress and heat stroke further. So you can't actively warm them to prevent that shivering response, and try your best to maintain them within the closest to the reference range you can, 97, 98 up to 103, 103.5, depending on those fluctuations. But yeah, I usually don't let them keep going if they are developing hypothermia.
How soon during the treatment process are you starting GI protectants? And when you
Um,
do start them, are you doing pantoprazole and or famotidine?
Almost immediately. So yes, so I will typically do so. As we're all accustomed to, the literature goes all back and forth as far as the efficacy of proton pump inhibitors versus H2 blockers. In these cases, sometimes I'll hit them kind of multimodal. A lot of the research with famotidine specifically looks at its efficacy as given as a CRI, which most people don't do, and obviously that can be a kind of cumbersome. And so for these guys, even on the triage table, I would like to get some pantoprazole into them, and then once they're admitted into the ICU, these are the cases I'll do BID every 12-hour pantoprazole, and even consider the addition of an H2 blocker as well, just to kind of hit them with multimodal antacid support for that gastroprotection.
Great. Would you recommend the 1/4 shock dose method?
What's that now?
Would you recommend the 1/4 shock dose method?
Oh, for isotonic crystalloid resuscitation?
That's what I'm thinking, yeah.
Yeah,
Quarter dose.
yeah, quarter shot dose. So that's largely employed for patients that are otherwise healthy and can handle adequate or can handle rapid resuscitation. And so when we think about it, looking at a quarter shot volume for a typical 90 mil per kg blood volume for a dog, that's on average about 22 mils per kg. Some people may even start at 10 mils per kg, which is more judicious, but 22 mils per kg is for your Labrador Retriever, my sister's Doberman that she called me about last night, which is like a 10-month-old Doberman. Perfectly fine. Now, cases where we may need to be a little bit more cautious and not immediately employ that quarter shock volume would be geriatric patients or patients that, if we have a 13-year-old Chihuahua who unfortunately also sustains heat stress and heat stroke that has a grade 5 murmur, we may need to be a little bit more cautious in our resuscitation plan for that patient because they can't handle the acute volume load. And that with, if they have valvular insufficiencies or whatnot, they may be, we may tip them into congestive heart failure if we give too much too fast. And so that's why I say we can always add more and titrate fluids. So in a patient that you have concerns as far as its ability to withstand or to take on the larger volumes of fluid quickly, you can always start with smaller aliquots, 5 mil per kg, 10 mil per kg, and then work your way up because it's easier to give more, but it's hard to take it back. Obviously in those cases, even with just typical fluid overload without any other subclinical cardiac disease, the implementation of diuretic therapy is still not an immediate fix for fluid overload. And so the quarter shock is to kind of a generalization for otherwise healthy patients that can be resuscitated fairly quickly, but it's really a patient by patient basis depending on what their underlying kind of cardiovascular system is.
Great, thank you. I think last question here, and I should have asked you this before we got started, is would you be comfortable with these slides being shared when we send out the CE certificate? And you can say no.
Yeah, that's fine by me. Yeah,
Okay.
no problem.
Okay. Well, I don't have any other questions here. A lot of thank yous. And so reminder that we will be sending out a CE certificate within the next week, and we'll include a PDF of these slides. Dr. Mathis, thank you so much for sharing all your knowledge and answering all these questions as we all prepare for the summer. And here is a slide of our CEs that are getting ready to come in May, June, and July. So please log on and join us again in the future months. And Dr. Reed, I see your question, and the answer is yes. I will reach out to you and we can make contact. Thank you, everyone. Hopefully everybody has a good night and a happy summer. Here it comes. Bye.
See ya.